Hi everyone, today I will be doing a case presentation to pancreatitis. AD is a 62-year-old male who came into the emergency department with excruciating pain that has been getting worse, and now he is unable to eat or drink. He reports he has history of emphysema. He is a chronic smoker for over 20 years and drinks alcohol at least 2 glasses a day for the last 20 years. He also reports he's having severe pain in the tip of his stomach that is now radiating to the back. He hasn't been eating as much since the pain seems to get worse when he eats and causes him to throw up. He's been feeling nauseous and hasn't had much of an appetite. Upon physical presentation, he is noted to have malaise. His pain is reported a 10 out of 10 that is intermittent. His cardiac assessment indicates hypotension with a blood pressure of 72 over 67. He has a low-grade fever of 37.9 Celsius, and his mucous membranes are dry. Respiratory assessment indicates dyspnea with a respiratory rate of 22 and shallow breaths. O2 sats are 92% on room air. Gastrointestinal assessment is indicative for tenderness upon palpation to the left upper quadrant. Decreased PO intake is indicative for dehydration. Based on the subjective and objective signs and symptoms, I am diagnosing this patient with pancreatitis. He has many risk factors and hallmark symptoms of pancreatitis. Men are more often to develop acute pancreatitis because of alcohol consumption, and AD has a history of alcohol consumption of over 20 years that places him at risk for pancreatitis. Furthermore, hallmark symptoms of pancreatitis include abdominal bloating, tenderness, diarrhea, jaundice appearance, loss of appetite, nausea and vomiting, upper abdominal pain. Abdominal pain often is described as steady, boring pain that worsens with eating and is usually focused on the epigastric region of the abdomen and can radiate to the back, flank, chest, or lower abdomen. He is presenting with epigastric pain that is radiating to his back, and he reports it worsens with eating. In severe cases of acute pancreatitis, the patient may also present with fever, brady, or tachycardia, or shortness of breath. In the case of AD, he is also presenting with hypotension and dyspnea, which is evident with the pancreatitis. Diagnostic tests to order would be lab tests, which would include a CRP, white blood cell count, amylase, lipase, a CT scan with contrast of the abdomen. The CRP will be elevated, showing inflammation. The serum amylase and lipase will be elevated 3 times the normal level. The white blood cell count, specifically the leukocyte count, will be elevated, and the CT of the abdomen will show necrosis of pancreas. Treatment will include IV fluid for hydration, analgesics for pain management, and antiemetics such as Zofran for nausea. IV fluid replacement is the cornerstone of pancreatitis treatment and the most important part of the first 48 hours after its diagnosis. Early fluid replacement improves hemodynamic parameters and has positive impacts on microcirculation, as well as critical complications such as pancreatic necrosis and organ failure. And this slide is a list of my references. That concludes my presentation. Thank you guys.